Okay, for the next question, Dr. Kim, if lorlatinib and brigatinib are not yet available in my country, what treatment options do we have after progression on alectinib? And specifically, they added alectinib plus chemotherapy. Is adding immunotherapy beneficial?
Right, so really good question. I think adding chemotherapy to alectinib is certainly a reasonable option to think about, good option, especially for those who have known brain metastasis, because what we know about chemotherapy is that it doesn't really work fantastic in the brain. So we probably need help from alectinib for disease control in the brain. And there are many regimens out there. There's a platinum plus pemetrexed plus minus bevacizumab, and even plus minus atezolizumab based on data from IMPART 150. They looked at the EGFR ALK positive subsets in the IMPART 150 and showed a pretty good benefit with the quadruplet therapy compared with the chemotherapy and bevacizumab. Some speculation about the data is that the alectinib or the ALK positive patients were relatively small compared with the EGFR patients. So is the benefit that we saw there with the quadruplet therapy of carbotaxol, bev, atezo was driven by EGFR patients versus ALK, that we really don't know. And I haven't seen any specific data from that clinical trial looking at ALK positive non-small cell lung cancer yet. And so we need more data from that IMPART 150 trial. But certainly adding chemotherapy is a good option. A continuation of alectinib even after progression can be strongly considered in those who have known brain mets, even without brain mets, to protect the CNS progression, I think.
I definitely agree. In our practice, if we are having to choose between on top of the chemo anchor, are we going to add immunotherapy or are we going to try and continue the ALK-directed therapy? Our practice usually is to try and keep the ALK-directed therapy going, precisely for the reason Dr. Kim cited about either ongoing control of CNS metastasis or protection of the central nervous system. The reason we tend not to do chemotherapy plus ALK-TKI plus immunotherapy is then we do worry about toxicities. As you add more and more medications, you are at higher and higher risk for potential side effects. Now, there may be an instance where the cancer is clearly not sensitive to ALK-directed therapies. If the cancer has become so ALK-independent that there is clearly no dampening or control of the disease that's happening from these TKIs, then we might consider kind of putting that aside, at least for a time being, and then trying to explore other strategies.
And one downside of doing the quadruplet therapy with the carbotaxol, bev, atezolizumab may be that you cannot, continue ALK-TKI in that scenario. It's hard because there's as Dr. Lin mentioned, there is increased side effects when you combine TKI and immunotherapy. Then for those who really need ALK-TKI to protect the brain, that may not be the best approach.